Hello everybody, this is a quick run through on the use of diffusion imaging for the assessment of bone metastases as part of whole body examinations. These are my disclosures. You'll note that there will be some discussion on the off-label use of drugs, equipment and software. So we find ourselves in 2016 in a difficult place. We have imaging tools commonly used that lead to poor confidence in assigning clinical states and for assessing therapy benefits. So when we think patients have M0 disease, in fact they turn out to have M plus disease, and when we think they have oligometastatic disease, they in fact turn out to have polymetastatic disease. And I'd just like to illustrate that with an example. Here is a 52-year-old female with a grade 3 breast cancer, ER positive, HER2 negative. At staging, we find the presence of a single lesion. Is this oligometastatic disease at presentation? Well, when the SPECT scan is done, we find a second lesion. Here it is in front, and here it is on the sagittal reconstruction. It's in the sternal bone. When we do the whole body MRI, however, we find that there are nearly 13 bone metastases. So what we thought was oligometastatic disease is in fact polymetastatic. So the first question we really need to ask ourselves is how good are CT and bone scans for detecting the presence and the volume of metastatic disease. A few years ago now, this meta-analysis was published, which looked at 145 studies with a variety of tumors, looking at the ability to diagnose bone metastases. And essentially it shows that both at the patient level and at the lesion level, PET and MRI scans have an equal performance, but both are more accurate than CT and bone scans for the detection of bone metastases. So if we look at the ROC plots, we can see that the performance of FDG PET scans is very good, as is the performance of MRI scans. CT has good specificity, but the sensitivity is reduced. And bone scans, the current standard of care, has a very variable performance. We should really be thinking again about the role of bone scans for the staging of patients. Another study looked specifically at prostate cancer and used choline PET as the comparative technique. And again, essentially the study shows the same effect, that fluorocholine PET CT has a good performance for detecting metastases, MRI scans has a good performance, whereas the bone scans are really all over the place, and in fact in this study and in this study they are close to not being very good, or in this particular case a toss of a coin. The other problem is that we have a limited ability to depict heterogeneity of biological behavior to treatments. This heterogeneity of biological behavior can be observed with more sensitive techniques such as whole body MRI scans. So this is the same patient that I showed you previously, who was treated with aromatase inhibitors, and what we see is that some metastases do get better, and here is a metastasis that does get better, and we can follow it over time. It's still persistent, but still present. But look what happens to this metastasis over here. We can see how it grows over time. And this is the classical picture of secondary resistance to aromatase inhibitor therapy, and this recent article looked at this whole question and showed very nicely that this secondary resistance is due to the emergence of mutants in the ligand binding domain of the ESR1 estrogen receptor, making these tumor cells, these red ones here, relatively estrogen independent, resulting in the late emergence of areas of therapy resistance. Now it turns out that the volume and the heterogeneity of response to treatment are increasingly important for treatment prescriptions. I just wanted to concentrate on the issue of volume. If we look at this data published in the New England Journal in 2015, what we observe is that patients with high volume metastatic disease do benefit from androgen deprivation and docetaxel when they are chemo naive. If we look at low volume disease, we see that in fact, although the hazard ratio is similar, there is no separation of these curves at 5 years. Now it may be that these curves do separate over time, but it is certainly the case that low volume disease can be treated by ADT alone, whereas high volume disease should be treated now with a combination of ADT and docetaxel. Now, how was high volume disease defined? High volume disease was defined by the presence of visceral disease or more than 4 bone scan lesions, at least one of which was in the appendicular skeleton. In other words, the volume of disease for metastatic castrate-naive prostate cancer definitely alters the treatment prescription for patients. Another problem with the current way of doing this is we are unable to identify who is not benefiting early after starting treatment. As a result, we fail to detect primary and secondary resistance at an early time point, which impedes the progress of patients to alternative therapies. And I just wanted to give you an example of that. So here is a patient receiving a targeted therapy against the AR receptor in castrate-resistant prostate cancer. So you can see that at the start of the study, the patient has retroperitoneal lymph nodes. The bone scan is normal. At 13 weeks of therapy, we can see the PSA is nicely suppressed. The signal from the retroperitoneal lymph nodes have gone down. The bone scan has stayed normal. And what we observe is that at week 25, we see a single emerging lesion. We know this lesion is new because we have 2 prior scans, and we can focus in on this area and identify this new metastasis. So this is treatment resistance, because the bone scan is normal and the standard of care is the bone scan. The patient continues to receive treatment. Now at week 37, the PSA is still suppressed. We see 2 lesions. On the MRI, we're now seeing 5 lesions compared to the single lesion. Now, is this disease progression on the basis of the bone scan? The answer to that is no, because the Prostate Cancer Working Group 2 criteria requires that any new lesions seen after the flare period be confirmed to be called metastatic disease. So this patient then undergoes more treatment. So here is the follow-up. The follow-up shows that there are several emerging lesions. The previously documented MRI lesions are in fact larger. So at this point we confirm progression. That's after 49 weeks. Now, the actual date that the MRI detected progression was 25 weeks. We confirmed progression at 49 weeks, and what's recorded in the notes is 37 weeks. That constitutes a delay in calling disease progression, which can result in delays in starting the next therapies. Now, many of you will say that the guidelines recommend the use of CT scans also to assess response, so that should be okay. Well, it turns out that it's probably okay for soft tissues, but you really have to be very careful with bone disease, because progression can happen in front of your eyes and you can't even see it. And here is an example. So this patient has an ER positive, HER2 negative breast cancer. You can see that she has metastatic disease. On her next occasion, she is monitored with a CT scan. The CT scan looks unchanged. The disease is called stable. Then the patient undergoes another CT scan. At this stage, the CT scan is suggesting possibly some disease progression. It's quite difficult to see where, but I guess, over here, for example, next to the SI joint, there seems to be some sort of change, and here, just underneath the disc, within S1, we see some change. Now, what's really dramatic is what is happening in the bones on the MRI scan. You can see on the MRI scans that this patient is got marked disease progression. So this disease progression has taken place in front of your eyes, and you didn't even realize it because of the intervening CT scan and not an intervening MRI scan. And if you look at the MRI scan, you can see the emergence of new lesions and a huge increase in volume in the burden of disease with, in fact, the development of liver metastases. So in terms of this particular patient, we started off with small volume disease. The patient was asymptomatic. Now we have large volume disease, we have liver disease, and the patient is now, in fact, mildly symptomatic. So, because of the CT alone that was done at the mid-time point, we don't know whether the patient was progressing, whether the patient was stable, or whether the patient had responded. In fact, we lost the ability, the opportunity to use less toxic treatments when disease volumes were lower and the mutational heterogeneity was much less. For this patient, this is a disaster. In fact, the patient went on to be treated with palbociclib and an ER degrader, which was Faslodex, and we'll follow her up later to see how she is getting on. Another one of the problems with CT scans is that sclerotic progression and sclerotic response are really difficult to distinguish, partly because the bone changes are indirect interactions between tumor cells and the matrix. And I just wanted to show you an example. So here is an example of a patient being treated with a PARP inhibitor, and you can see a very nice example of what is commonly described as sclerotic progression. So we can see that there are new areas of ground glass, ill-defined calcification within the bone marrow, and the lesions are in fact getting larger. This constitutes progression. We can confirm that with the MRI scans, which also show enlargement of previously noted lesions, in this case of sclerotic progression. Now, this pattern is in fact quite difficult to distinguish from sclerotic response. So in fact, the same patient then went on to receive carboplatin, and you can see that she's developing sclerosis. Now, this is new sclerosis. you should not interpret this as disease progression. In fact, this is sclerotic response. And this is a really difficult determination that radiologists repeatedly fail to make. So let's look at the evidence overall. Whole body MRI scans detect more malignant lesions per patient and fewer benign lesions compared to bone scans. Overall, the FDG PET and MRI have about equal accuracy. And I just thought I'd show you an example of another malignant lesion. In this particular case, this is small cell lung cancer, and I just thought I'd show you a lateral view and an anterior posterior view. The FDG PET, this is the DWI in the middle, and here are the bone scans. Even if you subtract out the soft tissue disease, you can see that the bone disease is much better depicted by the FDG PET and by the MRI scan. And in fact, if you look at the spinal images, you can also see the one lytic lesion detectable on the CT scan, and these other smaller lesions that are visible on the MRI scan are not really seen on the CT scan. Now, you mustn't go away thinking that bone scans are completely useless. In fact, it turns out that there are certain types of patients in whom bone scans are actually very good. I just thought I'd show you an example of a sclerotic metastasis. You can see the bone scan is positive. You can see the CT scan is positive. But if you look at the MRI scan, what you observe is that on the diffusion image, this is a negative defect. It's not a bright spot. So there are some osteoblastic lesions which can be false negative on the diffusion imaging, but will be identifiable on morphological MRI. So here's an important lesson to learn, that whole body MRI scans should be combined with morphological sequences to improve specificity. Now, what you mustn't go away thinking is that sclerotic disease is always hypo-intense on diffusion-weighted sequences, and in fact it turns out this isn't the case. So here's a patient with extensive sclerotic bone disease. You can see that the FDG PET scan is negative, the DWI is positive. This is not surprising, this patient has lobular carcinoma. If you were to look at the morphological CT scans, you will see that there is a lot of sclerosis. But if you were to then look at high resolution images of the bones, you'll see that although this is a sclerotic deposit, there are lots and lots of spaces here which have tumor cells, which then gives us the positive whole body MRI scan. So false positives and false negatives do occur. You need to be aware of those, and I've just left up a list here today just to list them for you. I'm not going to illustrate any of these in detail. These are covered in other talks that you will find on this website. Now, this is our activity of whole body MRI scans over the last few years, and you can see that we are roughly doing between 80 and 100 scans a month now. The biggest indication is in fact breast cancer, followed by prostate cancer, and myeloma is a few cases, but not as many as in other centers. So what is driving this performance in metastatic bone disease? We perform whole body MRI scans when conventional imaging performs poorly when it comes to detection, for assessing tumor volume and therapy response. And this is already what I've said to you. We know that CT scans, for example, can give a very confusing appearance when there's lytic and sclerotic disease and it's mixed. And we know that serum markers don't always help. So for example, PSA in the castrate resistant state is less helpful. CA15-3 in breast cancer only has a sensitivity of about 65%, and in oligosecretory disease in multiple myeloma, this is another indication for the use of whole body MRI. I just wanted to show you an example of somebody who had oligosecretory prostate cancer. You can see that this patient has a PSA of 13.8 to start with, has quite a lot of bone disease, gets treated with docetaxel times 3, times 6, and then times 10, and we can already see by times 10 treatments that the patient is developing resistance. So if you look over here, you can see that there is already some disease progression. The chemotherapy was stopped. We monitored it, and as expected, the patient progressed. The patient was then treated with cabazitaxel, and you can see that the patient responds. Again, not completely. We monitored the patient. Again, you can see the relapse, and then we waited again for a bit longer, and you can see now there's a large volume of disease. The patient then switches to abiraterone, and the patient is followed on abiraterone, and you can see that the disease improves with abiraterone. So the question is, what causes these changes that are observable on the whole body MRI scan? This is illustrated by this cartoon, and you can see this patient was treated with docetaxel times 4, and we can see that the signal intensity decreases, the apparent diffusion coefficient map goes up quite a lot. There's a shift of the histogram to the right. I think this is shown better on this particular diagram, where we can see the prior histogram and the post-treatment histogram. And that shift is related to cell kill, which is shown here stylized on this graphic on the right. We can then take this data and back project it on the pre and on the post-treatment scans, and you can see where the patient is responding. That's these green areas where the patient has resistance, and here we are, look, in the lower lumbar spine, and in the right femur and the left femur also, and the right ischium. So it's possible to back project these to find out exactly where response is occurring and where response is not occurring. How does one then begin to codify these observations on whole body MRI scan? Well, there was a Metroid system that was published in 2016 for the use of whole body MRI scans in metastatic cancer, specifically focused on advanced prostate cancer. But many of the principles on quality assurance, on data collection, on response assessment are in this document, and I'd highly recommend that you read it if you get a chance. Now, one of the things that it has been recommended is that response is graded on a scale of 1 to 5. So here is a grade 5, meaning that the patient is highly likely to be progressing. And here are the criteria for disease progression. So the appearance of unequivocal new lesions, an increase in the size of lesions, when focal lesions become diffuse pattern, when you get increasing soft tissue disease, for example. And here's an example of somebody who develops disease progression. So we can see this is primary resistance to an AR directed therapy. We can see new lesions, we can see enlargement of previously noted lesions, and clearly this is progression. Similarly, we see nodes in the pelvis enlarging, and even the recurrence in the prostate gland is also enlarging with bladder involvement. Now, you can quantify that, and if you quantify that, you can see that this patient starts off with about 155 cc's of tumor, and then very shortly thereafter you can see that the patient has 540 cc's of tumor in a time interval between April and August 2016. So that is an example of highly likely to be progressing. The Metroid system also enables you to identify areas highly likely to be responding and likely to be responding. So let me just show you an example of something that is likely to be responding. So here's the patient with metastatic breast cancer, again ER positive, this time being treated with an aromatase inhibitor. If you look between examination number 1 and examination number 2, you would probably call that stable or minimally improved. On examination number 3, you would say probably stable since examination number 2. But on examination number 4, you would say definitely progressing. If you look at the diffusion weighted images, you can see the same pattern. We can see here that there seems to be some reduction in signal intensity. That signal intensity reduces further, but then the patient progresses. Now, it's possible then to map, as we did previously, where responses are occurring. So here is the pre-treatment histogram. This is examination number 1. You can see on examination number 2 we see a right shift of the histogram to the right, but it doesn't seem to cross our cell kill threshold of 1500. On examination number 3, what you notice is that there does seem to be further response. And in fact that's shown on the histogram, and you can see this is the histogram on occasion 3. But there are lots and lots of red areas here indicating ongoing active tumor, and you can see straight away that on the next occasion she's clearly progressed. So the histogram of examination number 4 and examination number 1 are identical. So there was some response, it lasted for a short time, it came back. This is a classical example of secondary therapy resistance developing. So let's just summarize where we're at. When you have metastatic bone disease, you can treat locally, you can treat systemically. The current method of doing this with serum markers, bone scans and CT scans only really gives you 2 response categories, progression and no progression, and this alters the way an oncologist thinks about their patient and his or her therapy choices. The new methods of doing this, using whole body MRI scan, PET scanning, serum markers, circulating tumor cells, etc., enables us to break this paradigm. So instead of having 2 categories, we now have 3 categories: response, stable and progression. And this exactly matches what happens in soft tissue disease. That will have a different effect on oncologic thinking regarding therapy choices, and hopefully that will change the way that the care for these patients is delivered. Thank you very much for listening. I hope you found this informative.